Our next talk is going to be by Laura Tang. Laura Tang is a pathologist at Memorial Sloan Kettering, and she is recognized as one of the world's most experienced and knowledgeable in this area. And it's really an honor to have her speaking here with us today. And she's going to talk about pathology, the impact and behavior of tumors. Thank you, Laura.
Thank you, Dr. Howe. Good morning, everyone. I'd like to take the opportunity to thank Marianne and Bob for their tireless effort of organizing this over the years. As you can see, I'm a pathologist, and I don't normally see patients. However, this is a great pleasure for me to see many of you in the same room. I wish I had the opportunity to ask you what kind of questions you have, but I'll try my best to address some of the most relevant pathological issues. So when you were told that you were diagnosed with a neuroendocrine tumor or neuroendocrine neoplasm, you probably will reach out to find to do some tests, including radiology, biomarkers, as mentioned in the last talk. And you may also go through nuclear medicine to have a octreotide scan or even PRRT for treatment. And also you may have to see intervention radiologists to have a biopsy. And instantly you will get on the internet to look for the best surgeons and the best oncologists in this area. However, it is very important.
Speak in the microphone because I can't hear you in the back.
However, it is very, very important that you have the correct diagnosis. Without the diagnosis of from pathology, which is a gold standard, you will none of these surgeons or oncologists will treat you. And worst of all, if you had the wrong diagnosis, your treatment may be delayed, and or you may have the wrong treatment, which may cause some unnecessary damage. So I just want to explain to you what we do in pathology. Some of you may not be aware. So first of all, you will receive tissue, either from surgical resection, biopsy, or aspiration, or body fluid. And then the tissue, we describe the tissue of its size, shape, and consistency. This is called gross description. And next, we fix the tissue in formalin and fixed in formalin, embedded in paraffin, and cut very thin sections like this in 4 microns. So, and then these are placed on glass slides and then stained with hemotoxylin and eosin H&E stains. So this is the basic material we use for diagnosis. And sometimes, so this is a microscopic diagnosis with H&E. And sometimes you probably will be asked to have additional slides, additional material for other ancillary studies such as immunostains or even molecular diagnosis. So in general, what we do in pathology is to accurately diagnose the tumor, provide the tumor stage, that is how far the tumor has gone in your body, and provide the tumor grade. And then hopefully some of these will provide both prognostic as well as therapeutic indications. So the outline of my talk is, first of all, overall of the disease, and then some specific pathological issues. So you may know that endocrine organs, in general, this is what we know, that's something you could feel with your, such like thyroid when it's enlarged, or you can see on a CT scan or even X-ray. So these are neuroendocrine organs, such as thyroid, parathyroid, adrenal glands, and pituitary. However, there's another system that cannot be detected by CT scan, and we can only appreciate these the cells or organoids under the microscope. For example, in the pancreas, these are cells of islets, neuroendocrine cells. In lung, these are called Kaczynski cells. In the GI tract, and there are different type of neuroendocrine cells. So as I mentioned, these cells do not form an organ. So these are individual tumor cells inserted into the epithelial glands, and they are quite powerful in terms of physiological function. They can release, upon stimulation, they can release material which can interact with adjacent cells, as well as releasing into the bloodstream or the adjacent nerves. So in the pancreas, these are group of cells, and here is a microscopic example of an islet, which is composed glucagon-secreting alpha cells or insulin-secreting beta cells. So you have seen this many times, but in general, for neuroendocrine tumors derived from these so-called diffuse neuroendocrine cell systems, in general, in the upper gastrointestinal tract and the lower tract, they appear to do better, which is not necessarily reflect their biological behavior. I think it is because they can be detected earlier through routine endoscopic procedure. However, as you can see, even within the same organ, you can have different types of neuroendocrine tumors. So the biology also dictates the prognosis. In the small bowel, they appear to do worse. However, this is not purely due to the biological behavior. This is because the early detection is almost impossible in certain circumstances. So in general, I want to focus on GI and pancreatic neuroendocrine tumors. They represent a heterogeneous group of tumors, and they all produce neuroendocrine markers such as chromogranin, synaptophysin, and the others mentioned in the earlier talk. And histologically, this is derived from so-called diffuse neuroendocrine cell system, not from other epithelial cells, such like adenocarcinoma. And nomenclature is tricky, but I think if you don't remember anything from my talk, these are the two most important things one should remember. One is so-called well-differentiated NET. We used to call them carcinoid in the GI tract. Another is a poorly differentiated neuroendocrine carcinoma, which these are completely two different entities. I will emphasize on these issues throughout my talk. So this is what we see under the microscope, different types of neuroendocrine tumors. For you, this may look like colorblind test, but for me, it provides some clues where these tumors are coming from. So this is very important in the circumstances when we have so-called unknown primaries. We have a small liver biopsy, and clinical workup has not indicated a specific primary site. Through these morphological features, I can have a relatively accurate assessment. Some of them are from the duodenal tumors are glandular forming. They have a little bit, as we call Sonoma bodies or calcium deposition inside. And the most common pattern for pancreatic neuroendocrine tumor is like this. For small bowel, you have these very distinct peripheral palisading. And for rectal tumor, you have a lot of blood lakes, as well as this very small cores of cells. So with the experience, I think these morphological features are very helpful when we're dealing with unknown primaries. So in terms of pathological features of these tumors, first of all, I think these are the relevant, clinically relevant issues. There are many other academic issues I won't have time to go through. Again, I want to emphasize the most important thing is to distinguish NET and the neck. These are two completely different neoplasms in terms of their histogenesis as well as clinical behavior and therapies. And tumor differentiation, this is also very important to mention in the initial diagnosis. This is what that means is how closely the tumor cells resemble their normal counterpart cell lineage. In terms of neuroendocrine tumor, how closely they resemble the so-called the cells from the diffuse neuroendocrine cell system. Tumor grade usually represents the biological aggressiveness of the tumor. It doesn't really tell exactly what kind of tumor it is, because sometimes, in rare occasions, a well-differentiated tumor can have a higher grade. So classification is very complicated. I don't want you to remember any of this. I just want to show you the complexity. As you can see, many organizations are involved, including WHO, European Neuroendocrine Tumor Society, American Joint Cancer, as well as SEERS. So you can see in general describes the grades and stage, and sometimes they're mixed. So it's very difficult to comprehend what that means. So I want to use this slide. Albert Einstein says, if you cannot explain it simply, you do not understand it well enough. This is probably the situation we have. So how can I simplify this complex system? Again, I want to go back to my initial statement. It is important to indicate the differentiation of a tumor, because these are completely two different neoplasms. Neck, only one word difference, but it makes a whole difference in the clinical scenario. So grading, the tumor can be graded by proliferation. Again, I want to emphasize this is not used to classify the type of tumor. It only tells you how aggressive the tumor can be. So WHO in 2007 updated the pancreatic neuroendocrine tumor grade, and I believe the GI gastrointestinal neuroendocrine tumor is coming early next year. So in general, there is a well-differentiated NET can have different shades, different grades by either mitotic activity or KX67. And poorly differentiated has no, although it's called G3, but it doesn't have different shades, is inevitably high grade. As you can see, the overlapping proliferative activity indicates that you cannot use this proliferative activity alone to classify the tumor. So in a well-differentiated tumor, there are very few mitotic figures. As you can see here, there's only one. And so if I look at this, for example, if this is a one microscopic field, I can see either one or none. So if I only count 10, I may underestimate the proliferative activity. So we recommend it to count 50 high-power fields. And you can see both can indicate the prognostic features. However, if you count more, appears to be a little bit better to separate the prognostic curve. So again, in a well-differentiated tumor, you can have different grades. Even within the same tumor, you can have very low grade. In the other microscopic field, you have a higher grade, or even up to the G3 level. And as an experienced pathologist, we also pay attention to detailed cytological features. For example, this is again taken from the same tumor. You can appreciate subtle differences, and the nuclei here are slightly larger than this one, and there are many more mitoses even within this microscopic field. So this is a well-differentiated tumor which can be heterogeneous in grades. Here's another example of a lower grade part, and in the higher grade portion you have a large nuclei, and you start to appreciate microscopic foci of tumor necrosis. So what does it mean in terms of tumor grades in a well-differentiated tumor? Obviously, it can separate prognostic curves. However, it really does not have very significant therapeutic value unless there's a clinical significant disease progression. So back to the higher grade tumor, so we call it poorly differentiated neuroendocrine carcinoma, and the mitotic rate is usually much higher than indicated here, but this is the lower cutoff end. So in general, these tumors have a very different clinical picture. First of all, they may have a rapid disease progression. A clinician can tell me if I made a wrong diagnosis about this tumor. Oftentimes, the disease may progress by days. Otherwise, in a well-differentiated tumor, I would hear from the clinician that the patient is doing well and working full-time and exercising with normal activities. So in addition, PET scan usually is positive, octreotide scan is usually negative or focally positive, and other biomarkers can also be elevated, such as CA 19.9, CA 125. And morphologically, as indicated earlier, we have some clues. They represent either small cell or large cell type neuroendocrine tumor. And they can commonly seen in association with another type of carcinoma, such as adenocarcinoma or squamous cell carcinoma. And they can be positive for neuroendocrine markers on immunostains such as chromogranin or synaptophysin, but they're usually not as strongly or diffusely positive as in the well-differentiated counterpart. And as you know, it's a refractory to chemotherapy, and the prognosis is poor. And most importantly, it has a totally different therapeutic targets, so it is extremely critical to have the correct diagnosis at the very beginning. So we think what's happening in a high-grade polydifferentiated neuroendocrine carcinoma, they started off, they are not derived from so-called diffuse neuroendocrine cell system, as I mentioned earlier. They're actually derived from conventional glandular or squamous epithelium. They can have a large cell type or small cell type. Small cell type does not really reflect the size of the tumor. So we think what's happening is they started off as a conventional carcinoma, and they undergo some molecular genetic transformation and become a neuroendocrine carcinoma. So here are some examples. Under the microscope, they have large areas we call a geographic pattern of necrosis, and they can form so-called rosettes in the large cell variant, or small cell when you see the nuclei are very condensed, confluent together. And you may see in this example, there is a combined glandular carcinoma and neuroendocrine carcinoma. So just to put this together again, these are completely different from well-differentiated neuroendocrine tumor. These are carcinomas, and they have a different cell lineage, and they only have one grade. It's not necessary to give them a different grade. And up to 50% can have a combined conventional carcinoma. And when we run molecular markers, they are very similar to conventional carcinomas and different from neuroendocrine tumors. And clinically, I mentioned earlier, the markers and the presentations, the prognosis are different. And therapeutically, also different. So to put the two together, to emphasize the difference between the two, well-differentiated neuroendocrine tumor started off in the diffuse neuroendocrine cell system in the gut or in the lung, in the cells of islets in the pancreas, and they may have different shades. The lower grade lower grade tumor usually has a stable disease for many years, and they may progress to a higher grade we call G3, which is associated with disease progression clinically. In contrast, polydifferential neuroendocrine carcinoma are not derived from neuroendocrine cell lineage. They are conventional carcinomas, and they become neuroendocrine carcinoma during the transformation, or de novoli have the genetic signature, and only one grade and rapid disease progression. So this may not be a perfect analogy, but I want to just to make my point. As you know, married people, most of you do not share, usually share the same last name, but you are usually not genetically or biologically related. So our neuroendocrine tumor and neuroendocrine carcinomas, this is, sorry, go back. Here's Mr. and Mrs. Neuroendocrine. They are not related, and they're different. So no offense to the gentleman, I couldn't find another slide. I just want to make my point. These are not related. As alluded earlier, this is used to grade a tumor, but not used to classify the tumor of its specific type. As you can see here, there's overlapping proliferative activity between well-differentiated neuroendocrine tumor G3 and the polydifferentiated neuroendocrine carcinoma. So high-grade, so-called high-grade neuroendocrine neoplasm. I call neoplasm when I don't know whether it is a T or is a C. So I use neoplasm when I cannot be sure. So including both these entities, and can be very, very difficult in a small biopsies. So this is what we. I don't want you to remember. You should have the slides on this later. I don't want you to remember all of this, but this is just indicate the diagnosis of a G3 tumor when in a small biopsy requires combined clinical input as well as ancillary studies, immunostains, pathological consultation, and even molecular diagnosis. And this phenomenon is not common in the GI neuroendocrine tumors, G3 subtype, but it's more common in the pancreas. That's why we could use some of the molecular markers in the pancreatic neuroendocrine tumors. So differential diagnosis in small biopsies can be challenging. I just want to give you some examples. So in general, some of these tumors are diagnosed by fine needle aspiration, usually done by CT guided aspiration. And you can go on with the description, but when it comes to reality, it can be quite difficult. Here is an example of a neuroendocrine tumor in the fine needle aspiration. There are very few cells in this sample. You can see there's a vague vascular core in the middle, and the cells are hanging on this vascular core, so which is indication of a neuroendocrine tumor. And cytologically, these cells have a very abundant cytoplasma, and the cells are relatively large, and you can do a immunostain of neuroendocrine marker to identify the tumor. Here's an example. It's a very interesting case. It's a neuroendocrine tumor. The cells are quite large with some nucleoli, and the immunostain for chromogranin is diffusely positive. So this patient presented with a peripancreatic mass, and the patient was taken to the OR. And we had a diagnosis of a neuroendocrine tumor, which is not wrong, but the patient had a hypertensive crisis in the OR. Some of you may know that this tumor produces a hormone which can have cause hypertension. So for me, a diagnosis of neuroendocrine neoplasm is only half of a diagnosis. And there are different entities one have to think about it. Again, we mentioned a tumor and the carcinoma, as well as a conventional carcinoma with neuroendocrine carcinoma or pheochromocytoma. So in the small biopsy or final aspiration, we need to distinguish the type, and we try to provide a differentiation if we can, which is critical, poorly differentiated or well differentiated. And the grade, we may not be very precise in terms of G1, G2, G3, but at least we should provide information whether it is a high grade or not high grade. So another area is we often receive is small biopsies in the liver because it's easy access, or the patient comes with the unknown primary situation. So the issue here is that we oftentimes do not have adequate clinical information, or the patient has not been fully worked up. And or also the biopsies are relatively small and not very well preserved. So I want to give an example just to emphasize the importance of a team effort. So this is a case I encountered a few years ago. This is a woman, 71 years old, history of breast cancer in 1994, and then recurred some years later with lymph node metastasis. So you can see the disease is still there. And again, a few years later, presented with abdominal pain and the abnormal liver function. So you can appreciate there are many lesions in the liver. Obviously, one jumps to her history, which is a breast cancer. And again, the biopsy is very, very suboptimal. You cannot really appreciate the architecture of the tumor, and the individual cell morphology is also not appreciated in this suboptimal biopsy. And so outside diagnosis came with epithelial neoplasm consistent with metastatic breast cancer. So when I saw this, this is what we receive every day. Everything is a rush. The patient is not doing well, and we need to start a chemo now. So pressure is on, and we said the preliminary, this could represent the breast cancer, but we really need to exclude other possibilities, and we would like to see her prior breast pathology. However, as you know, in Manhattan, we don't have much space, so her prior breast specimen was stored in Bronx, which takes some time to get them. And so at the same time, I have some unstained slides, and I performed a chromogranin synaptophysin stain and turned out to be positive. And estrogen receptor and progesterone receptor were negative, so this is probably not breast. So just looking at this morphology, as I alluded earlier, morphological features can provide some clue where the primary can be coming from. So to me, this has some features of a pancreatic neuroendocrine tumor, PANNET. So I asked the question to my clinician, is there any lesion in the pancreas? The answer was no. But there's a mass in the spleen. And to me, this is very unusual. Spleen is not a common site for metastasis. So we look at the CT scan here. Obviously, there's a tumor in the spleen. But when you look at the serial sections and you see here's pancreas, and there's a tumor at the tail of the pancreas, which going into the spleen. So at this time, we got additional information. The patient is not doing well. The patient has a diarrhea, watery diarrhea, electrolyte imbalance. So this tells me this could be a very specific subtype of pancreatic neuroendocrine tumor. So I did a VIP immunostain. So it turns out this patient has a lipoma, which typically causes watery diarrhea. So finally, there are some other pitfalls in diagnosis. When we receive a very small specimen, you can see the cells are very, very crashed. You cannot really appreciate individual cell cytological features of individual cells. And this is actually commonly seen in the high-grade neuroendocrine carcinoma of small cell type. We see this very often. In this situation, Ki67 is crucial, which indicates the proliferative activity is very low, so this cannot be a small cell carcinoma. So for us, we have established a minimal pathological pathology data set to diagnose these tumors. And we need to provide, as a pathologist, we need to provide information for classification, as mentioned again, well-differentiated versus poorly differentiated. And we need to provide grade information by mitotic activity and the Ki-67 index. And we need to provide the tumor stage, particularly in surgically resected tumors. And immunohistochemistry is required for minimal, diagnosis of neuroendocrine tumor by chromogranin or synaptophysin. And margins, obviously, in the resection specimen is critical. And we also need to provide other evolving factors which can indicate diagnosis and prognosis. So the take-home message is that as a pathologist, when you look at a pathology report, you should really focus on these two entities. If it is not mentioned, you should challenge the pathologist. And again, I want to mention the team effort. Sometimes it's really impossible for us to just look at the under the microscope without clinical information, particularly the specimen is small and suboptimal. And therapeutic decisions should be based upon the correct diagnosis of tumor classification, tumor grade, tumor stage, as well as available biomarkers. So as a pathologist, we are usually accused to be too slow. They're always waiting for the diagnosis. However, if we are equipped with the correct information, we can run just as fast. Thank you very much.